Okay, so today we're going deep on some pretty important stuff you really don't want to mess around with. Endocrine conditions.
Yeah, these are the ones that can really throw your whole system out of whack.
Exactly. And we're zeroing in on a few big ones today. Diabetes mellitus, of course.
Right, and we'll be digging into thyroid issues too, both hyperthyroidism and hypothyroidism,
And then rounding it out with adrenal insufficiency.
including those really scary adrenal crisis situations, the kind of thing where quick action can make all the difference.
Absolutely. We've got a whole pile of medical info here to sort through.
Yeah, enough to make your head spin. But don't worry, that's what we're here for.
We're going to break it down, give you the need-to-know stuff, cut through the jargon.
So you can really understand what these conditions are all about, how they can go sideways, and what you need to watch out for.
Let's kick things off with diabetes mellitus. It's probably the most well-known of the bunch, but there's still a lot of confusion around it.
Definitely. From what I'm seeing here, it's defined as a group of metabolic diseases where the main issue is high blood glucose levels.
Right, hyperglycemia. And that happens because the body's either not making enough insulin or not using it effectively. Insulin's the key here, right?
Exactly. It's like a gatekeeper for glucose,
Yeah.
letting it into your cells for energy. Now, here's where it gets a bit tricky. There are two main types of diabetes, type 1 and type 2.
And they're pretty different beasts, right?
Oh, yeah. In type 1, it's like your immune system goes rogue.
Rogue cow.
It starts attacking those beta cells in your pancreas, the ones responsible for making insulin.
So it's an autoimmune thing?
Exactly. And the result is usually you end up with no insulin production at all. It's like the factory gets shut down completely. Sometimes you can see these little red flags in the blood tests, things called islet cell or insulin antibodies.
Those are signs of the attack in progress.
You got it. Now, type 2 diabetes, that's a different story. Much more common too.
This is the one we often link with lifestyle, right?
Yeah, things like diet and exercise play a role. But it boils down to what's called insulin resistance. Basically, your cells aren't responding to insulin like they should.
So the gatekeeper's there, but the door won't open.
Kind of. And your pancreas tries to compensate by pumping out more and more insulin.
Working overtime.
Exactly. But eventually, it just can't keep up, and that's when you start seeing the problems. You might also have a situation where the pancreas just isn't producing enough insulin in the first place. It's like it's gotten tired and lazy.
So no matter the type, we're talking about a chronic condition here, right? Something you have to manage for life.
Absolutely. And the real worry with diabetes is all the complications that can come from constantly high blood sugar. It's like a slow burn that can affect almost every system in your body.
Yeah, our sources are pretty clear about that. They talk about both metabolic complications, messing with how your body uses energy, and vascular complications.
Affecting your blood vessels, right? And those are further divided into macrovascular and microvascular.
So big blood vessels versus tiny ones.
Exactly. Think about your arteries getting clogged up, that's macrovascular. And then the damage to the tiny capillaries, that's microvascular.
And that can affect everything from your eyes to your kidneys.
Absolutely. On the metabolic side, you also see changes in how your body handles fats and proteins, all tied back to that lack of insulin action.
Now here's a glimmer of hope. The sources emphasize that keeping your blood sugar well controlled can really help prevent or slow down those microvascular complications.
Huge point. It's all about managing that blood sugar roller coaster. And that goes for oral complications too, things like gum disease.
So let's get into the nitty-gritty of those complications. Metabolically, we've got ketoacidosis and hyperosmolar non-ketotic coma. Scary names, but serious stuff.
Yeah, and from what I'm seeing, that hyperosmolar non-ketotic coma is more common in type 2 diabetes.
Then you've got the cardiovascular risks. That's a big one.
Definitely. Accelerated atherosclerosis, that's like the fast track to heart disease. It's all about plaque building up in your arteries.
And high blood pressure is a big problem too. 2/3 of people with diabetes have it, according to our sources.
And the scary stat is that their risk of having a stroke or dying from heart disease is 2 to 4 times higher than people without diabetes. That's a sobering thought.
Makes you realize how crucial it is to get this under control. And it's not just the heart. We're talking eye problems, retinopathy, cataracts.
Kidney problems too. Diabetic nephropathy can lead to kidney failure.
And then there are the feet and leg problems. Increased risk of ulcers, gangrene, even amputations. Diabetes is a leading cause of those non-accident-related amputations.
Not to mention diabetic neuropathy, which is damage to the nerves caused by high blood sugar.
And that can manifest in so many ways, right?
It's crazy. You can have digestive problems, swallowing issues, even erectile dysfunction. Then there are the classic symptoms: numbness, tingling, burning pain. It can affect your muscles, your balance, everything.
And the worst case scenario, our sources say diabetes is the 7th leading cause of death in the U.S., with heart disease being the most common culprit.
So yeah, this is serious business. But let's talk about management. What are some of the key things to consider, especially in a medical or dental setting?
Well, it seems like if someone's diabetes is well controlled, routine procedures are generally fine, no special precautions needed.
But if there's any sign of poor control or maybe some undiagnosed issues popping up, then a medical consult is absolutely necessary. Better safe than sorry.
And a simple thing like using a glucometer to check blood sugar on the day of a procedure can be super helpful. Gives you that real-time picture of what's going on.
There's also a specific drug interaction to watch out for. Patients taking sulfonylurias, a type of diabetes medication, should steer clear of aspirin and other NSAIDs.
So ibuprofen, naproxen, those types of things.
Exactly. Now, it doesn't look like there are any specific restrictions on local anesthesia or vasoconstrictors for people with diabetes.
But of course, you'd use them judiciously with any patient, taking their overall health into account.
Absolutely. And when it comes to scheduling, morning appointments are generally preferred for anyone with diabetes.
Makes sense. And remind patients to take their usual insulin and eat normally on the day of the appointment, right?
Yeah, and confirm that they actually did when they get there. Sometimes people forget in the hustle and bustle.
Our sources also give us some concrete numbers to work with. If fasting blood glucose is below 70 milliradial or 3.9 millimol, elective treatment should be postponed. Or you give the patient some carbs to boost their blood sugar.
Right, and on the flip side, if it's above 200 milligdl or 11.1 millimol, you also delay treatment. And in that case, a referral to their doctor for further management is a good idea.
It's like those numbers are the red flags, telling you to proceed with caution. Now let's talk emergencies. Hypoglycemia, low blood sugar, what are the signs?
Well, you've got the classic hunger pangs, feeling weak and shaky.
Headache, sweating, maybe a rapid heartbeat that feels weak.
And they might seem irritable, have trouble speaking clearly, look pale.
Tingling sensations are common too. And in severe cases, seizures. That's a 9/11 situation right there.
Definitely. And then you have some subtler signs: mood changes, low blood pressure, feeling cold, and of course, a blood glucose reading below 3.0 millimol confirms it.
Okay, so what do we do if we encounter someone experiencing hypoglycemia?
First things first, get them upright or at least semi-upright.
If they're conscious, right?
Right. And give them something sugary to drink. Juice, soda, anything to get that blood sugar up quickly.
And while you're doing that, keep an eye on their vitals.
Absolutely. Now, if they become unconscious, it's 9/11 time. Lay them flat, open their airway, give them oxygen if you have it, and monitor those vitals until help arrives.
Medical help might involve giving them intravenous dextrose or glucagon, a hormone that raises blood sugar. Okay, let's switch gears to hyperglycemia. High blood sugar, what are we looking for there?
Think excessive thirst, peeing a lot, that rapid weak pulse again.
Blood pressure can be normal or even low. And they might be drowsy, have dry skin, almost hot to the touch.
And then there's that telltale fruity breath odor.
Classic sign. They'll probably complain of feeling incredibly tired and weak.
And you might notice blurred vision, changes in their mental state. Blood sugar readings above 15 millimol confirm hyperglycemia.
And sometimes you see something called Kussmaul's respiration. That's a type of deep labored breathing. The body trying to compensate for a buildup of acid in the blood.
Right. So for a conscious patient with hyperglycemia, get them upright, give them oxygen if you can, and call 911. Again, monitor those vitals.
The same story if they lose consciousness, except lay them flat, open the airway, oxygen 911, and watch those vitals like a hawk.
Okay, ready to move on to the thyroid?
Let's do it. First up, hyperthyroidism.
Our sources tell us that thyrotoxicosis is the big umbrella term here. It means you have too much thyroid hormone, T4 and T3, coursing through your bloodstream.
And that can happen for all sorts of reasons, right?
Yeah, you could have thyroid tissue in a weird spot, like your neck or chest. That's called ectopic thyroid tissue.
Or you could have a multinodular goiter, which is basically an enlarged thyroid with lots of nodules, or a thyroid adenoma, which is a benign tumor.
Right, or inflammation of the thyroid, called thyroiditis. Sometimes it's a pituitary gland issue, or even taking too much thyroid hormone medication.
But the most common culprits are Graves' disease, toxic nodular goiter, and acute thyroiditis. So what are the key management points for hyperthyroidism?
Well, if it's poorly controlled, medical consultation is a must, and any routine treatments should be put on hold until it's better managed.
And blood pressure monitoring is crucial, right? It can be elevated in these cases.
Absolutely, and this is a huge one. Avoid using those retraction cords impregnated with epinephrine. Even a tiny bit can be a problem for these patients.
Yeah, our sources say a 1-inch cord contains 3 milligrams of epinephrine, and that's enough to potentially trigger some serious cardiovascular issues.
Same goes for using epinephrine in local anesthesia. Big no-no in untreated or poorly controlled hyperthyroidism. But if it's well controlled, you're usually good to go with local anesthesia.
Okay, let's flip the script. Hypothyroidism, what's the deal there?
Well, it can be congenital, meaning present at birth,
Hmm.
or acquired, meaning it develops later in life.
And acquired hypothyroidism has a bunch of potential causes, right?
Oh, yeah. Thyroid problems, pituitary problems, radioactive iodine treatment, surgical removal of the thyroid, even some medications can cause it.
It's like a whole domino effect. But the most common types are primary hypothyroidism and goitrous hypothyroidism.
Right. That's about 95% of cases, according to our sources.
So how do we manage hypothyroidism in a medical or dental setting?
Well, if it's poorly controlled, get a medical consult first. And if it's completely uncontrolled, elective care is off the table until things are stabilized.
There's also the issue of medications. Severe, uncontrolled hypothyroidism means avoiding CNS depressants like narcotics.
Right. Those can be risky in that situation, but if it's mild and well controlled, you can use them cautiously, maybe at a lower dose.
Always better to err on the side of caution. Now, there's a really scary complication of hypothyroidism called myxedema coma.
Yeah, that's a life-threatening emergency. You're looking for severe hypothermia, slow breathing, low oxygen levels, high carbon dioxide levels, and low blood pressure.
It's like everything's shutting down.
Pretty much. So what do? Call 911 immediately, keep the patient warm, monitor those vitals. Treatment usually involves intravenous hydrocortisone, thyroxine, saline, glucose, and dextrose.
And if they stop breathing, CPR is the next step. Okay, last but not least, adrenal insufficiency.
This one's all about the adrenal glands not producing enough hormones, mainly cortisol.
And it can be primary, secondary, or tertiary, depending on where the problem originates.
Primary adrenal insufficiency, also known as Addison's disease, happens when the adrenal cortex itself is damaged.
Secondary is usually a pituitary gland issue, not sending the right signals to the adrenals.
And tertiary is a problem with the hypothalamus, even higher up in the chain of command. Long-term corticosteroid use is a common cause of that one.
And the bottom line is adrenal insufficiency can be life-threatening if not managed properly.
So, in a medical setting, if it's poorly controlled, get that medical consult and delay any non-urgent treatments.
Stress management is important too, right?
Absolutely. Anxiolytics and sedatives can be helpful during stressful procedures, and continuous blood pressure monitoring is a must.
And then there's the issue of steroid supplementation.
Yeah, that's crucial. The normal adrenal output is about 25 milligrams of hydrocortisone per day.
But during stressful procedures, patients with adrenal insufficiency might need a boost.
Especially if they're already on steroids or have certain risk factors.
Things like poor health, pain, infection, long-term steroid use. Those folks might need 150 milligrams of hydrocortisone on the day of the procedure and the day after.
It's all about giving their system the extra support it needs to handle stress. Now let's talk about adrenal crisis.
Right,
That's the real emergency situation.
So what are the red flags?
Sudden severe pain in the legs, lower back, abdomen.
Vomiting, diarrhea leading to dehydration, low blood pressure, confusion, dizziness.
You might see fever too. If they're conscious, cool them down, start 5E fluids, call 911, give them oxygen, and administer either hydrocortisone or dexamethasone.
And if they're unconscious, same deal, except lay them flat. 50% dextrose IV might be needed, plus the hydrocortisone or dexamethasone and maybe epinephrine to boost that blood pressure.
So wow, we've covered a lot of ground here. Diabetes, thyroid issues, adrenal insufficiency, and all the ways they can go wrong.
It's a lot to take in, but hopefully it's given our listeners a good overview of these conditions and why they need to be taken seriously.
Absolutely. And it really highlights the importance of that careful patient history, understanding their medical background. It can make all the difference in preventing complications.
And I think it also makes you think about the interconnectedness of the endocrine system, how one imbalance can trigger a cascade of effects throughout the body.
It really does. Makes you wonder how many seemingly unrelated symptoms might actually be traced back to a subtle endocrine issue. That's something to ponder.
Definitely food for thought. And on that note, we'll wrap things up. Thanks for joining us for this deep dive into the world of endocrine conditions.
Until next time, stay curious and keep learning.